Hi everyone, it's Hunter Hicks. We're going to look at some male reproductive diseases or disorders today. So when we look at these, some common ones we can see is urethritis, which is going to be inflammation of that urethra. Now this doesn't always have to be infectious, but it definitely can be caused by infection like STDs, stuff like that. Patients are going to come in with painful urination, itching. They might also have urinary frequency as well. Epididymitis, which is inflammation of the epididymis, is also usually caused by infection like STIs. Now, the reason we see a lot of their signs and symptoms is because the epididymis, which we know is where we contain a lot of our sperm, is right there on the testes. So they can a lot of times get that scrotal pain, they can get scrotal swelling, but they can also get inguinal pain and stuff like that. Now, a varicocele is when we have abnormal dilation of the vein. This usually happens around puberty with kiddos. And it's usually kind of seen as like a bag of worms because you'll see one of those veins are dilated, so it almost kind of looks like that. Now, usually that a varicocele is usually going to be left-sided and seen very often in puberty. Hydrocele is one of the most common reasons we see scrotal swelling when people come in. Hydrocele is going to be kind of a collection of that fluid there. And it can be seen in newborns, usually will go away, but can also be seen chronically in older men. The biggest thing is it's easily transilluminated if we put a flashlight under it, and it's usually or just painless. Cryptocorticism is the last one. So cryptocorticism is when we know that when the fetuses are developing, that the testes actually start in the abdomen. Eventually they descend down to where we see them. Well, cryptocorticism is when the testes don't get... They're not allowed to descend all the way down, so we kind of have a rest of that descent. Now, the biggest thing with this is it can happen with both full-term and preterm kiddos, but it does put them at risk for testicular cancer and infertility. Therefore, a lot of the things we do is usually surgery for cryptocorticism. However, there is still a high risk of infertility with these patients even after surgery. When we look at BPH, very, very common thing to see in the elderly male, we know in general that the prostate is going to be around our urethra and helps secrete fluids to help out with semen. Now, obviously, it's literally around the urethra, so anytime it's hyperplasia or overgrowing, it can cause issues and kind of pinch on that urethra, cause this mechanical obstruction. That's why a lot of the signs and symptoms we see are urge to urinate, delay in urination. They could have the decreased force of urinary stream. The bladder doesn't completely empty. And they also are at risk for different things like kidney infection, bladder infection, all those things. Now, some of the causes, we know in general we start to see hyperplasia around 45, and then that just keeps going as they get older and older. That's why patients over 75, 90% of them are going to have some degree of BPH. Now, we know there's some disruption of growth factors, especially like testosterone or androgens, stuff like that. That's where we use some things to help block those. So let's look at the treatment for our BPH. So really we break it down for very large prostates, so these patients have really severe symptoms, or mildly large prostates. For very large prostates, we're going to give 5-alpha reductase inhibitors. And what 5-alpha does, it takes testosterone and converts it to dihydrotestosterone, okay, DHT. So when we block 5-alpha reductase, we don't get that DHT. And we think this is a cause of obviously BPH. Now the good thing is we're only blocking the DHT normally around that area and not so much systemically. One of the most common ones we see here is finasteride or Proscar. And the biggest thing with the side effects or adverse reactions of these 5-alpha reductase inhibitors is they do protect against small or low-grade prostate cancer, but they might actually increase the risk for large-grade prostate cancer. When we look at mildly large prostates, I'm going to switch to our alpha-1 adrenic antagonist. And we've covered these. These are really used for blood pressure, right? If we antagonize alpha-1 receptors in the systemics, we get lower blood pressure. But we also have alpha-1 receptors or smooth muscle receptors in the prostate. Therefore, we can block that. Now, as you can see, there's really two classes of this. They are the medications that block alpha-1 throughout the whole body, which makes sense, but then their side effect is obviously going to be hypotension. Then there's ones that only block the alpha-1 receptors in the prostate, like Flomax. The good thing about those guys is they don't really have that adverse reaction of hypotension like our non-selective doxazocin, which we know doxazocin, sorry, that should be Cardura. Doxazocin is used for high blood pressure, but as you can see, it's also going to block the alpha receptors in the prostate. So for that reason, all these non-selective can cause hypotension, whereas our selective don't cause that many adverse reactions like hypotension. Last but not least, when we look at sexual dysfunction, which sometimes we just commonly call now erectile dysfunction. There's a lot of causes. There's vascular issues, there's endocrine issues, chronic issues like chronic renal failure, especially patients on dialysis, tons of patients with diabetes, central nervous system issues like Parkinson's and multiple sclerosis, tumors. Different surgeries can put you at risk. A lot of some of our medications we give can cause this as well. In general, we can see this over the ages of 65 as well. Now, what we do know is when we have an erection, we see the CGMP causes increased vasodilation and everything like that. And that's the erection that the male wants to see. However, PDE5 is this enzyme that actually breaks down CGMP. So we came up with the idea, or pharmacy came up with the idea of PDE5 inhibitors. Therefore, if they block PDE5, our CGMP stays around longer. Therefore, you get a longer and better lasting erection for these males. So good common examples of PDE5 inhibitors are like sildenafil, and these other guys you see here. Now, they can cause issues like hypotension, even at their normal doses, but obviously if you were to give one of these guys with a BPH medication, that could cause issues as well, because both of them are going to cause hypotension together. Priapism, or an erection lasting longer than up to 4 to 5 hours, is a medical emergency, and they need to seek ER care, where we're going to do aspiration of the organ itself and then usually give some degree of a catecholamine like phenylephrine. Headache, flushing, dyspepsia. Some of the precautions and contraindications, we never want to give this with nitroglycerine. Nitroglycerine increases CGMP formation. Okay? So as you can see, if a PDE5 slows the breakdown of it, like sildenafil, a PDE5 inhibitor like sildenafil slows the breakdown of CGMP, and nitro just increases the formation. By giving those two together, we'll have a ton of CGMP, so they're really at risk for hypotension. There's also some research and data that patients on these medications, PDE5 inhibitors, have a possible increased risk for cardiovascular events. Now, they really weren't sure, was it the PDE5 causing it, or was it that the patients were partaking in sexual function, like they were partaking in that. Maybe that was causing a lot of increased oxygen consumption, maybe that caused it. But nonetheless, they're really careful giving these medications to patients with MIs in the last 6 months, resting hypotension or high blood pressure, heart failure, or unstable angina. That's all I have for you guys. Very quick, down and dirty. Leave me a comment if you'd like, and I'll see you next time.